Good morning, good afternoon, and thank you for joining us for today's VIA VitaFlow in Association with You live webinar. My name is Michelle Harrington. I am a registered dietitian on the Medical and Scientific Affairs team with VitaFlow North America. We are excited to bring you this educational activity and introduce our speakers. Today's topic is nutrition pitfalls and strategies for success in managing adults with AKI or on dialysis, how innovative nutrition products like RenaStep can help. Please note, this program is being recorded. Next slide, please. Support for this presentation was provided by VitaFlow North America, a Nestle Health Science company. The views expressed herein are those of the presenters and do not necessarily represent Nestle's views. The material herein is accurate as of the date it was presented. It is for educational purposes only and is not intended as a substitute for medical advice. Please note that questions will be addressed following the presentation. However, you are welcome to submit text questions into the Q&A pane at any time during the program. If you have any questions relating to VitaFlow product or any of our resources, feel free to contact your VitaFlow representative for product information following the program. You can access a PDF of the slides in the chat. This program is not eligible for CPE credit. Now, I have the pleasure of introducing our speakers today. Rory Pace has dedicated her career to nephrology nutrition, a field in which she is a leader, educator, and a patient advocate. Rory earned a bachelor's degree in dietetics from the University of California, Davis, and a master's in public health from UCLA. She has been a board-certified specialist in renal nutrition for 20 years. Rory has published and presented on numerous nephrology nutrition topics and is co-author of the 2020 Standards of Practice and Standards of Professional Performance for Nephrology Nutrition. An active volunteer leader, Rory currently serves as past chair of the Academy of Nutrition and Dietetics Renal Dietitians Practice Group, and as a member of the NKF Spring Clinical Meetings Planning Committee. Rory has served in a number of other leadership roles in the Academy of Nutrition and Dietetics and NKF CRN. She was recognized as Outstanding Dietitian of the Year for California by the Academy in 2020. Rory previously served as Senior Director of Nutrition Services at Satellite Healthcare, using her clinical and leadership experience to guide clinical practice for over 120 nephrology dietitians across the U.S. She is a strong advocate for the role of nutrition in care of people with kidney disease and has been a key player in the development and implementation of numerous successful clinical initiatives. Julius Navarro is a clinical dietitian at the University of California, San Francisco Medical Center. He has 17 years of experience in nutrition and dietetics, 10 of which were spent in renal nutrition. He is also a special visiting lecturer at his alma mater, Polytechnic University of the Philippines, where he earned his Bachelor of Science in Nutrition and Dietetics. Currently, he is pursuing a Master of Science degree in Clinical Nutrition at Rutgers University. He is a board-certified specialist in renal nutrition and a certified nutrition support clinician. Julius is involved in different professional development and leadership roles with the Commission on Dietetic Registration and the AND Renal Dietitian Practice Group and the Council of Renal Nutrition. Julius received recognition as a fellow of the Academy of Nutrition and Dietetics and of the National Kidney Foundation. Next slide, please. Okay, so here are our learning objectives. Next slide, please. Today, we're going to start with an overview of RenaStep, This is an enteral nutrition product for kidney disease. We are including it in a case presentation that we've developed for you. So I thought it would be helpful to go over this product. AKI pathophysiology, protein energy wasting, nutrition intervention and nutrition support, transition of care, management of AKI in the outpatient setting, and finally, nutrition assessment, nutrition intervention. Next slide, please. Okay, so introducing RenaStep. This is a ready-to-drink enteral nutrition formula containing protein, carbohydrate, fat, including DHA. It has vitamins and minerals for a diet restricted in potassium, chloride, phosphorus, calcium, and vitamin A for the dietary management of kidney disease. It's suitable for use from 1 year of age and is for use under medical supervision. Next slide, please. Oops, yeah, thank you. RenaStep has a tailored nutrition profile for early enteral support. It has a special electrolyte profile and reduced protein burden for individuals with AKI not on dialysis. So features and benefits include low electrolytes and protein to support kidney function recovery. And as I said before, this is low potassium, sodium, chloride, calcium, magnesium, and phosphorus to help manage serum levels. 8% of the calories come from protein. This translates into 8 grams of protein per bottle of RenaStep. It is calorically dense at 2 kcals per ml to deliver calories and support fluid restriction. This is great if you're having patients with poor appetite as well. And then it's got a great taste with a very subtle hint of vanilla flavor to support transition from enteral to oral feeding. It's also got a very nice mouthfeel. It's very smooth and it's not a very heavy product. Like thinking heavy cream, it's not that heavy. So thinner mouthfeel. Next slide, please. So just quickly, I just wanted to show you the actual content of the electrolytes in RenaStep. It does come in the 200 ml bottle. And I'd encourage you to look at how this compares to some of the other products on the market. We were very deliberate about going low because we feel you can always add, but you want to start off low. And then importantly, this is not suitable for use as a sole source of nutrition. This does contain vitamins, it does contain minerals, but we have deliberately made potassium, chloride, sodium, etc. low, and you would want to carefully monitor levels if you were providing this as sole source or exclusively tube feeding. If you're giving this as an oral supplement and they're getting PO as well, well, you're getting other stuff from the diet. So really, it's just those electrolytes I would carefully want to be watching if you had it as sole source. Next slide, please. Okay, so RenaStep can be a very useful early intervention for enteral nutrition support in AKI in the critical care setting. The incidence of AKI in the ICU has been reported to be greater than 50%. So the first question you're going to want to ask yourself, can the patient be safely enterally fed with stable blood pressure and functioning gut? If the answer is no, probably at this time you'd want to be considering parenteral nutrition, PPN or TPN. If the answer is yes, you may need a low dose feeding, trophic feeds, and at the same time you may need concurrent parenteral nutrition. So then you're going to start thinking, well, I probably want to start with a low protein electrolyte formula and continue until renal function improves. So nutrition goal 1, start as early as possible. In the perfect world, 24 to 48 hours. Now, sometimes it is possible to be tube feeding these patients and it's not happening. Other times it's really not medically safe to be feeding the patient. So that's something very different. And then from there, as your renal function hopefully improves, you can transition over to a more standard formula. You won't maybe need the renal step anymore. So goal number 2 would be to progress feeds as tolerated to meet your nutrition needs. Next slide, please. I'll hand it over to Julius.
Hi, good morning and good afternoon to everyone. And thank you for this opportunity. And for today, so we'll be discussing AKI. So AKI is an abrupt decrease in kidney function that includes, but is not limited, acute renal failure. So there is a specific kidney disease that can cause AKI, such as acute interstitial nephritis, acute glomerular and vasculitic renal disease, and non-specific conditions such as ischemia, toxic injury, or extrarenal pathologies such as pre-renal azotemia and acute post-renal obstructive neuropathy. So it can can cause short-term and long-term morbidity with 26.9% mortality. So there are 3 causes of AKI, such as pre-renal. This is impaired perfusion results from cardiac failure, sepsis, blood loss, dehydration, and vascular occlusion. Or renal intrinsic, which is glomerulonephritis, small vessel vasculitis, acute tubular necrosis, nephrotoxic drugs, some toxins, prolonged hypotension, inflammatory disease, and infection. Whereas for post-renal, it is caused by urinary calculi, retroperitoneal fibrosis, benign prostate enlargement, prostate cancer, or cervical cancer. You can be exposed to any of those, or you may be susceptible from having sepsis or being admitted in the ICU if there's circulatory shock, or a patient got burned or trauma or any cardiac surgery or any major non-cardiac injury. Also, susceptibility from dehydration or volume depletion and advanced age, or even CKD patient can have AKI on top of their chronic kidney disease. Chronic disease involving heart, lung, and liver, or even diabetes, cancer, and anemia. So there is 26.9%, as I've said earlier, of mortality if you are diagnosed with AKI in the hospital setting. And the prevalence of AKI is between 3% and 18.3% in adult hospitalized patients, where 33 to 66.7 are admitted in the ICU. And 5 to 11% of those would be requiring kidney replacement therapy. It's either continuous renal replacement therapy or intermittent hemodialysis, which puts them to 55.3% mortality if they are receiving AKI. A systematic review of Core et al. Reported that an episode of AKI is associated with an increased risk of mortality as well as long-term adverse outcomes, such as new onset of worsening and chronic kidney disease, and dialysis dependence and cardiovascular disease. Therefore, it also increases the prevalence of protein energy wasting for patients with AKI from 67.9 to 82.1%. Oops. Okay, so for protein energy wasting, it is a term for kidney disease-related protein energy wasting who have lost muscle mass, energy reserves, and defined by the International Society for Renal Nutrition and Metabolism. At least 3 of the 4 listed categories and at least 1 test in each selected category must be satisfied to diagnose kidney disease-related protein energy wasting. Optimally, each criterion should be documented at least 3 times, preferably 2 to 4 weeks apart. So number 1 is the serum chemistry. So for your serum albumin less than 3.8, pre-albumin less than 30, serum cholesterol less than 100. For the body mass, there's an alteration in your body mass index, such as less than 23 of your BMI, unintentional weight loss, and total body fat percentage of less than 10%. For loss of muscle mass, there is a reduced mid-arm muscle circumference and muscle wasting of less than 5% in 3 months, or 10% in 6 months, and a creatinine appearance. So creatinine appearance, it is both muscle mass and meat intake related. Number four is the reduction in your protein and your dietary protein intake, or DPI, or dietary energy intake for at least 2 months. So patients in the ICU are at greater risk of protein energy wasting due to alteration in protein, carbohydrates, and fat metabolism. So this is due to the systematic effect of inflammatory syndrome seen in AKI. ESPEN guidelines on hospitalized patients with acute and chronic kidney disease recommends screening for malnutrition, especially for those staying more than 48 hours in the ICU. So let's see this case. So this is based on a real patient case, but we modified this for educational purposes. So AJ is a 60-year-old female and admitted to the ED due to recurrent UTI and hypotension with blood pressure of 80/40, and she was diagnosed with sepsis. Eventually, she was admitted in the ICU and was intubated with a mean arterial pressure of 50. And with looking at the labs, so all are red. So these are some of the classic indication for kidney replacement therapy in the setting of hemodynamic instability. So you have hyperkalemia, you have your uremia, you have your dysnatremia. Dysnatremia is less than 120 of sodium or more than 165 megs per liter. And potentially this patient could have some oliguria due to recurrent UTI. Um, on day three, patient was nephrology was consulted due to worsening AKI and volume overload, and continuous renal replacement therapy, or CRRT, was initiated for this patient. Okay, so for day six, patient remained to be on NPO status with running D5 normal saline, and they placed NG2 for feeding. So they consulted nutrition for tube feeding recommendation. Initially, we thought of continuous feeding as patient is still in the critically ill. So looking at the lab, so still BUN is still elevated, creatinine is elevated, potassium, phosphorus, and glucose, while sodium, there's an improvement, uh, reach the normal range. And for the lactate, it reaches 1.9, which helped us to decide on starting feeding with these patients. So the 2022 ASPEN consensus statement recommends initiation of tube feeding in adult critical patients with MAP of greater than 60, but should be held if MAP is less than 50. In a retrospective study by Mao et al. In 2020, serum lactate levels were associated with an increased risk of enteral nutrition intolerance in patients with sepsis, especially in elderly individuals. An elevated serum level, lactate level, may be an early predictor of enteral nutrition in elderly septic patients treated with vasopressors. However, further studies are called for to verify these findings. While ASPEN's 2022 consensus statement did not recommend using lactate level as monitoring parameter for enteral nutrition tolerance. So for our assessment, so AJ's medical history includes type 2 diabetes and hypertension, and she came in at 95 kilograms, and her usual weight is at 90 kilograms. So you can see there is around 5 kilograms weight gain, and due to insufficient data, we cannot identify if there's a weight change for the past months, given this information in our slides. So in this case, we can use the lowest recorded weight. So that's how we usually do it here in the acute care setting. So, or if there is a dry weight written in the notes, we can use that. And her actual weight may be inaccurate, as the patient may have some edema or fluid retention in the setting of kidney disease. So also, NFPA may not be appropriate at this time due to the current medical condition. So there's a lot of line connected to patient that we don't want to mess up that during our NFPE. Okay, so for the intervention, in a perfect world, we are recommending always, all the time, indirect calorimetry. But Mifflin St. may be used in this setting for estimating resting energy expenditure due to its 70% accuracy in patients with obesity. So though it has 31% underestimation and 7% overestimation, it is the common equation used in the ICU, which is close to indirect calorimetry. So AJ may also be at risk of repeating syndrome due to less than 50% of estimated energy requirements for more than 5 days during an acute illness, and we can start at 75% of estimated energy needs within 1 to 2 days. So for the protein, this is kind of controversial and a lot of debate on this, but the latest guidelines for of ASPEN 2021 recommends 1.3 to 1.5 gram per kilogram per day for critically ill patients with AKI on conventional intermittent kidney replacement therapy. Lastly, for the fluids, it may be challenging as she is getting CRRT. You can always collaborate with your team. And I usually follow nephrology and intensivist fluid restriction. But to give you an idea, this may be old conventional estimation fluids with a kidney disease based on output. So if the patient is having more than 1 liter output, we can recommend 2 liters. If it's less than 1 liter, we can recommend 1 to 1.5 liter. And if it's anuric, we can keep it 1 liter. Okay, so for given AJ's improving laboratory result, as you can see in the slide, we can start with tropic or trickle feeds at 10 ml an hour. So we are using arena step, and we're advancing to by 10 ml per hour every 8 hours to a goal rate of 40 ml per hour. So we can advance the tube feeding as tolerated while monitoring electrolytes for refeeding syndrome. So we can check phosphorus, magnesium, potassium for this patient, and then that will help us dictate whether or not we will be advancing our tube feeding to the goal. So this tube feeding provides 960 ml, 1,920 kcal, 38.4 gram protein, and 8.4 gram carbs per hour. So including carbohydrate load per hour may be helpful with the team to manage insulin doses, given that AJ has type 2 diabetes. So patient might be using some sliding scale or sliding scale insulin, so it will be beneficial. So you can also use additional modular protein. So for this case, I'm giving 48 grams, which will provide an additional 200 calories. And that total calorie will be 2,120, 86 gram protein using Rena Step plus modular protein. For the water flashes, the lowest that I've read in ASPEN guidelines is 30 ml per hour, 30 ml every 4 hours, just to help with the maintaining tube patency. And then just just work with the fluids with your team. And then, let's go back. Okay, so I want to share with you the post hoc analysis of the effort protein trial that my nephrologist shared with me. So this study evaluated the effects of high dose protein in critically ill patients who developed different stages of AKI. So they compared the effect of high protein greater than 2.2 gram per kilogram body weight versus the usual protein dose of less than 1.2 gram per kilogram body weight on time to discharge alive from the hospital. So there is 312 out of 1,329 randomized patients developed AKI, and 163 received higher protein dose, while 149 received the usual less than 1.2 gram per kilogram body weight dose. So the higher protein group was associated with a slower time to discharge alive from the hospital and higher 60-day mortality. In the subgroup study, the harmful effect of higher protein disappeared for those who received kidney replacement therapy. The author concluded that a higher protein dose compared to the usual dose is associated with worse clinical outcomes in mechanically ventilated critically ill patients with AKI. No effect of either higher or lower protein dosing was observed in patients with AKI who received kidney replacement therapy. The author also recommended that while more research is needed in this area, clinicians should reevaluate current guidelines for nutrition support in AKI. And another article is commentary on Godry et al. a comparison of two delayed renal replacement therapy initiation strategies for severe acute kidney injury in 2021. And this study reported a higher trend of mortality at day 60 in the more delayed group. In a multivariable analysis, the more delayed strategy was a risk factor for 60-day mortality. However, there was no difference in the rate of complications between the two groups related to AKI or kidney replacement therapy. What is the implication for us RDs? This is essential to know the goals of care for each patient to help us guide when to start nutrition support, either enteral or parenteral nutrition. From a nephrologist perspective, a higher protein and fluids coming from either enteral or parenteral nutrition could be challenging to wean off patient from CRRT. So that's one of the common complaint of my nephrologist to me in the inpatient side. So for AJ is continuously improving. On day 9, she was extubated, and the team consulted speech language pathologists to evaluate swallowing and advance to an oral diet. Day 10 recommended SLP recommended IDDSI level 4, puree with thin fluids, but keeping to feeding to maintain nutrition. So looking at the labs, there are improvements in phosphorus, sodium, and lactate continue to be at goal or normal range. So the RD recommended cyclic tube feeding since AJ's CRRT stopped and transitioned to intermittent hemodialysis, so we can use Renastep without protein or without protein modular at 65 ml an hour for 12 hours from 1800 to 6 a.m. So this will give AJ to eat during daytime. We can add modular if AJ does not reach protein needs from PO diet, and tube feeding plus modular will provide 780 ml, 1760 kcal, and 79.2 gram protein with carbohydrates at 14 gram per hour. Okay, so let's go to the next slide. On day 12, AJ did not meet caloric needs based from calorie count, reaching only 45%. So our adequacy is at least 75%. And there are times that the team would want to do like 2 days an extension just to check whether or not the patient PO intake is improving. So you can do either 1 day or 2 days. So SLP follow-up evaluation recommended level 6 soft bite-sized thin fluids, and NGT is only indicated for short-term use, no more than 3 to 4 weeks. So the RD recommended PEG placement. However, AJ refused, and we can continue cyclic tube feeding until she reaches her energy needs in this situation. Okay, so how we will be transitioning AJ to a different care. So on day 15, she was cleared for discharge, but still requiring hemodialysis. And we will be continuing cyclic tube feeding at night to support intake. So AJ, in an ideal setting, so this is a collaborative approach that should look like. So the RD should finalize tube feeding recommendation once patient receive or reaches the goal rate, and then the physician writes the tube feeding prescription for discharge. The case manager coordinate with the insurance to cover for DME and enteral supplies, and the RN educate the patients and or family for tube feeding administration. Additionally, RD can recommend outpatient follow-up appointments for tube feeding management. Since AJ is transitioning to the dialysis unit, the renal dietitian may follow up on her and assist her in deciding whether or not to get a new enteral access, either NGT or PEG on dialysis. So that's the end of my presentation. Thank you.
Thank you, Julius. So accompanying AJ's transition, discharging from the hospital to the outpatient setting, I want to start by talking a little bit about some of the challenges of how these patients are managed in the outpatient dialysis setting. So earlier in my career, people with AKI either remained in the hospital to continue to receive dialysis until recovery, or that they were deemed ESRD or ESKD end stage, or they were deemed as end stage and admitted to outpatient dialysis, even though they may not truly be in end stage at that point. So beneficially for these patients, in 2017, the Centers for Medicare and Medicaid Services issued a ruling to change coverage of dialysis to allow these patients to receive dialysis in-center hemodialysis outpatient setting. And so obviously this facilitated discharge of patients from the hospital and also increased the accuracy of that admitting documentation or diagnosis. The frequency of these patients coming to the outpatient setting really varies. I think it has increased over the years with this ruling change, which it may or may not be related to the accuracy of the documentation. I would say in my experience, where the dialysis center is located in proximity to, medical center may influence the, how frequently these patients are seen in the outpatient setting. But generally, I would say infrequently, ranging from, a couple per year to maybe a couple per quarter. To help support the clinical course and treatment and hopefully recovery of these patients, there is no limit to the number of treatments, either weekly or day or monthly, as there is for patients with end-stage kidney disease, with the exception that they can only have one treatment per day. Now, while there are some policy changes that facilitate care of these patients, there are some challenges, both operationally and clinically. Generally speaking, patients with AKI are at risk for poor outcomes when they are receiving care in the outpatient dialysis center. Julia's already shared the higher risk for morbidity and mortality in this patient group. And one of the reasons that there is more risk for poor outcomes is that there really is a lack of standardized protocols and tools for care of people with AKI in dialysis organizations. That together with the fact that one patient with AKI is not like the next really challenges the care teams in this setting to appropriately provide care to achieve good outcomes. People with AKI receiving dialysis in the outpatient setting are subject to the dialysis, what's called the bundle payment, which includes professional services like dietitians, as well as medications and labs that are related to dialysis. That means they have theoretically access to all the tools, but there can be some varying cost associated to the facility, particularly in the case of labs. These patients may require more frequent lab testing. The other consideration is that home dialysis is not currently covered for people with AKI. Julia shared a little bit about the nutritional concerns for people with AKI, and these extend to the outpatient setting. There is an acute inflammatory response caused by acute kidney injury, which increases morbidity, mortality risk, as well as the increased risk for protein energy wasting, which Julius also covered quite nicely. So in this patient population, we really have to balance the individualized tailored therapeutic diet recommendations for supporting recovery and management of acute kidney injury while avoiding hopefully protein energy wasting or worsening of protein energy wasting. And to that end, it may be necessary to liberalize some of the dietary restrictions or prioritize your interventions to encourage appropriate intake. And similarly, oral supplements may be required to help patients achieve adequate nutrient intake. Frankly, in my experience, I think that's true for all people on dialysis because everybody has an off day once in a while where they can't really appropriately meet their nutrition goals through food alone. So as we continue to think about the nutrition concerns for this population, it's really important to understand and appreciate all the things that influence our plan of care for the patient. So their stage of acute kidney injury, the underlying cause of their kidney injury, their renal replacement therapy, if any. And of course, in this case, we're talking about somebody on dialysis, but as Julius mentioned, your plan of care really can vary depending on renal replacement therapy. This can really significantly influence energy and protein needs over time. It is important to note that there is some risk for refeeding syndrome in this population, and that really depends on their baseline intake and nutrition status and the prior clinical course before coming to dialysis. In the acute care segment of this case study, Julius was thoughtful in his nutrition interventions and mentioned watching for refeeding syndrome, while patient was in the hospital. And so, hopefully every acute care clinical dietitian is also looking at these things. But it's just good to know, if this patient had stayed NPO and just got like a tube feeding started at the last minute before discharge and came to the outpatient setting, there could be some refeeding syndrome happening in the outpatient setting. So this is important to watch for. The other thing that's really key to understand, and Julius referred to this, is that assessing body weight is really tricky in dialysis in general, particularly in the setting of AKI, because fluid accumulation really masks body weight changes. And so thorough assessment is really important. So as AJ is discharged after 15 days in the hospital and transitions to outpatient dialysis, she's admitted for dialysis at the center the next day. And you can see here her admitting labs, BUN and creatinine elevated as we would expect due to AKI. And I will point out these labs can vary some, particularly now that this patient is on intermittent dialysis rather than CRRT, which, the C is continuous. And so you can see some variation there. Potassium higher than the normal range for somebody without kidney disease. I would consider this level marginal for patient with AKI, so something to watch. Phosphorus a little bit low. Glucose appears elevated, but it's important to note that in the outpatient dialysis setting, we run many shifts of patients a day. And so when we draw labs at the beginning of treatment, it's very infrequent that patients are fasting. And so we use a little bit more liberal criteria in assessing glycemic control and also need to look at more data points in doing so. Albumin remains depressed. There's that acute inflammation you see. Sodium a little bit low. Now upon admission, the team ordered urea clearance, residual urea clearance, or KRU, as well as urine volume, which was found to be a little bit low. And I'll talk a little bit more about those clearances as we go on. So at this point, receiving a new patient coming from the hospital with acute kidney injury, it's really important to do a thorough assessment. So this patient is continuing on her tube feeding, cycling at night at 65 mLs per hour, without complications. However, assessment reveals that she's only running 9 to 10 hours at night due to her appointments, which include, her dialysis treatments 3 times a week, but also other follow-up appointments as she recovers from this hospitalization and acute kidney injury. As far as her PO intake, she reports that her appetite is fair, is getting a little bit better. She's eating small amounts during the day, but she does complain of early satiety. She's generally eating 3 or 4 times a day, but on dialysis days, it may be fewer meals. Her current weight is 87 kilos, and you'll remember that her usual weight before she was hospitalized was 90 kilos, but she was 95 kilos at the time of admission. So you see the evidence of some of those fluid shifts through her clinical course. She's got minimal urine output, as we saw from that KRU test that included the total volume. In dialysis for people with end-stage kidney disease, we're looking at urea clearance to evaluate the effectiveness of their dialysis. And so that test was ordered mistakenly. What we really want to order for a patient with AKI is a 24-hour residual 24-hour creatinine clearance. And this will give us a result that can be compared to GFR, glomerular filtration rate, to evaluate kidney function. At this point, it is appropriate to do a physical assessment of this patient now that she's feeling a little bit better and a little bit more stable. And that assessment does reveal evidence of edema and some muscle wasting. So that is consistent with that low serum sodium. So having performed our assessment, we now want to look at developing a diet prescription and plan of care, nutrition plan of care for this patient. The recommendations here are the evidence-based guidelines and ranges for adequate nutrition. You can see they're pretty broad ranges, and these are specific to people with AKI on dialysis. And you can see there are, in addition to the broad ranges, some considerations, particularly when it comes to fluid. Generally speaking, fluid intake continues to be pretty limited, but we need to continue to assess frequently to identify when the patient may start to have a return of function and move into a diuresis stage, so they don't get dehydrated. And of course, if there was a recurrence of sepsis or new sepsis in this patient, fluid needs would increase as well. So again, we really have to watch closely to look for changes in the residual kidney function to identify whether there's a need to make a change in the protein, calorie, or fluid plan for this patient. How long that takes, hard to say. We would fine tune based on the labs. And, recovery could be days, it could be weeks, it could be months. So that frequent monitoring continues. So developing our plan of care, I've estimated her diet prescription to be approximately between 20 and 2,200 calories, 66 to 99 grams of protein. I will pause here to say one of the frequent questions and quandaries and things that frustrate us as dietitians in outpatient dialysis is, which weight do we use to base our calculations? The evidence-based practice guidelines for nutrition and kidney disease do not specify, because there is no evidence base to direct us to use any specific weight to make these calculations. For the sake of consistency and simplicity, I've used the corrected or adjusted weight that Julius used on the inpatient side of this and or used a range based on that adjusted weight and actual weight. So you can see the fluid restriction is fairly low, also keeping sodium low, phosphorus low, potassium's a pretty broad range there. Assessing her intake, she's receiving about 12 to 1,300 calories a day from her tube feeding and about 23 to 26 grams of protein, with about 400 to 450 mLs of free water. I really find it's a good practice to consider the free water content, estimated here at about 70%, versus the whole volume of the tube feeding or even of an oral supplement, just because generally speaking, we don't count fluid that's part of solid food as we evaluate fluid intake for people on dialysis. And so I think it's reasonable to consider or exclude the solute portion of the formula as well. From her oral diet, she's getting about 450 calories and 40 grams of protein, a liter of fluid, and has some higher potassium foods. So you can see she's still falling a little bit short on her calorie and protein intake, probably, um, and maybe a little high on her potassium intake, and definitely higher than she should be on her fluid intake, which is again consistent with the findings of the low serum sodium and the presence of edema. So at this point, now that I've assessed a patient from a nutrition perspective and developed an initial nutrition plan, really want to sit down with the interdisciplinary team and discuss the clinical course of the patient, to date, and going forward, and make sure that the whole team is engaged and everybody's on board. And I don't mean to say that that's my job being the dietitian on the team, but being realistic, we know sometimes as dietitians, we do have the vantage point to really understand the bigger picture of the patient, and we can really play a key role in kind of coordinating or managing the overall care of the patient. I will say, in this case, we've illustrated a nice handoff from the acute care side, from Julius to me in the outpatient side. Um, I wish I could say that happens all the time. It doesn't. So, it may be necessary for me as part of the interdisciplinary team on the outpatient side to, contact the hospital dietitian, or to, at a minimum, obtain the discharge summary and understand the course of care. I think the challenge on the inpatient side for somebody like Julius is he may not always know the discharge plan and know, who to reach out to help coordinate that care through the transition. So in discussing the patient with an interdisciplinary team, which would of course include the nephrologist, likely would recommend weekly labs and a weekly team meeting. There aren't, again, like really specified, regimented routines of care for people with AKI in the outpatient setting. So it's really easy for them to kind of fall off the radar. And I feel like something I can do as a dietitian is keep them on the radar. And again, I would request that the physician order 24-hour creatinine clearance so that he or she could assess the patient's kidney function at this stage. As far as my interventions with the patient, I would counsel on that fluid restriction. I would add 2 bottles a day of Renastep PO, either between meals or maybe with medication, to not compete with the PO intake of the meals. And this will add 400 to 800 calories and 8 to 16 grams of protein. And a little bit of fluid as well. So that'll help make up the calorie deficit. Will still probably leave us a bit short on the protein intake. So I would encourage intake of protein foods. This will also help get some more phosphorus in. As you might remember, that was a little bit low. And as Michelle pointed out, Renastep is a formula that is mineral restricted. And so sometimes when patients are getting a significant portion of their calories from a product like that is mineral restricted, you have to be thoughtful about how the PO portion of their intake is, composed. Would also provide some counseling on potassium. So after 4 weeks, AJ is stable on dialysis. Here you can see her updated labs. So BUN and creatinine still a little bit elevated, but they've come down. Potassium and phosphorus are looking much better. Glucose, still, I would say probably for a dialysis patient coming to treatment midday is most likely acceptable, but I would do some more assessment there of her self-monitoring data at home. Albumin is improving, but remains low. That can take some time to come back to normal if in AKI. Sodium now we see is elevated at 146. And we have obtained that creatinine clearance, which came back at 21 mLs per minute. And urine output has increased to 1,500 ml. So we're starting at this point to see that return of function, which is a really positive sign for this patient. At this point, the patient's weight has come down to 84 kilos, and the higher sodium indicates, maybe a little bit of mild dehydration. So we've gone from a, fluid overloaded state to a little bit of a dry state. So probably this current weight of 84 kilos is a little bit more accurate. You can see that represents some significant weight loss. Her PO intake has improved, but it's not quite there where it needs to be. She's tapered down on her tube feeding down to 50 mLs per hour and fewer hours, hopefully to encourage PO intake. This is something I would individualize. It could be done through bolus feeding, longer hours, lower rate. But the key would be to individualize. And she's experiencing some cramps after treatment, which would be a sign that she is, at or maybe a little bit below her dry weight and a little dehydrated. So at this point, it would be appropriate to transition her to a PO diet and add 1 to 2 bottles of Renastep per day, again, to help make up that calorie deficit, depending on her appetite or how her schedule may be disrupted by dialysis. Her fluid intake can increase up to 2 liters per day due to that increased urine output. I'd recommend repeating the creatinine clearance. How often this should be done really varies based on physician practices and the patient's course. Some may do it weekly. I've seen that frequently. Certainly, the patient should be monitored weekly, and we're hoping for a recovery. I would note at this point, again, recovery could be, quick. It could be delayed. Given that this patient did have diabetes, she is at risk for end-stage kidney disease in the future. That creatinine clearance of 21 puts her in stage 4 kidney disease. So even though this may be a point where she can get off of dialysis or would be able to soon, she's probably going to need to transition to a CKD diet that would be lower in protein to help hopefully prolong that kidney function. And I would add, this is probably that, perfect place to use Renastep as a supplement to, ensure she meets her nutrition needs. And that takes us to the end of our presentation. We've included some references for you. And at this point, I think we'll open up for your questions.
Thank you both for such an informative presentation. That really was excellent. So yes, if everyone could please submit your questions using the Q&A pane. I also wanted to remind you that the slides are in the chat as a PDF. Okay, Rory, we do have a question. This is from Kathy, and this is for you, I believe. For AKI patients on dialysis who are experiencing poor appetite and altered taste, is this coming from the AKI, or could this be coming from the dialysis, or could it be both?
Great question. Taste changes are certainly common in people on dialysis. Uremia is probably the #1 cause of taste changes. So that's what I would look at first. Usually that presents as a, bitter metallic taste in the mouth. There are some taste changes that result from medications like IV iron. And you can also have decreased taste perception or sensitivity from zinc deficiency. So those are some of the questions that I would ask if a patient complains of altered taste, just to try to focus in on, the suspected cause, which would then, of course, dictate your interventions.
Great, thank you. Okay, we have a question from Tara. Could you restate the main takeaway for clinical practice from the article, The Impact of Higher Protein Dosing?
Okay, so the main takeaway for that is it says that let me share. Let me put back on this trend. So the higher protein dose compared to usual dose is associated with worse clinical outcomes in mechanically ventilated patient, critically ill patient with AKI. But the effect of higher protein or lower dosing was observed in patients with AKI who received KRT. So in the article, they said that the risk of mortality is decreased for those patients receiving higher protein on AKI on CRRT. But for those patients not on CRRT, it increases their mortality according to the study.
Okay, thank you. Okay, this is from Anonymous, and actually it's for me. So just a clarification, I would guess that using Renastep low in potassium and phos would allow more favorite foods to be consumed that may be higher in phos and potassium in the oral diet that is consumed. Yes, we always say that. These patients get a certain amount of these micronutrients daily. So if you consume a supplement that is low, that does save you more coming from your PO diet. Rory and Julius, if you'd like to say anything different or elaborate, please do.
Oh, totally agree.
Okay, this I think could be for either. Is it better to do creatinine clearance or residual urea clearance for AKI and dialysis? Do we need to do both?
I would advocate that creatinine clearance is the key test to do. Now, certainly you could order both and have them run with the same set of specimens, which would be, urine and blood. But I don't think the urea clearance tells us as much since we're not as focused on dialysis adequacy with this patient population. And of course, even in a end stage, chronic dialysis population, we can't report the KT over V, the clearance metric, including residual function. So I have found that to not be a helpful piece of information in this population, but it is something that tends to get ordered just because that's the routine for people with chronic kidney disease.
Okay. So I'm going to ask this question to my two friends from California. Can you comment on what you're seeing with the current plant-based protein, lower animal protein trends in CKD?
Actually, that is really there's a lot of study right now on that. So a study by Dr. Kamyar about the Play-Doh. So there are reports that improve kidney function, but there is no but we need more evidence to support that claim. But if your patient would like to do that, that is fine. And I experienced that before in dialysis, but I haven't seen any improvement yet for this patient. So it could be a case-to-case basis or individualized approach to that.
Yeah, I would agree. Certainly, as we look at the burden on the kidneys of protein foods and animal protein foods in particular, incorporating more plants and sources of plant protein seems to be beneficial based on emerging evidence. Unfortunately, there wasn't enough evidence to support a guideline in the current version of the evidence-based guidelines, but I would expect that we'll probably see that in future versions. And so I think that this product, can fit in. I think that's part of the question here.
Okay. Question for Julius. So with these really high levels of AKI in the intensive care units, is it correlated with older age or having health problems, or are you just seeing it all over the board in terms of patient profile?
So yeah, all older age they are susceptible, like I've discussed earlier, if you are advanced age because of the decline in kidney function. So after 30 years old, your kidney function or your glomerular filtration rate decreases by at least 10% per every decade
Yeah.
of your age. So that is a susceptibility. And if you are having some chronic diseases, such as I mentioned earlier, like heart, lung, or liver, which is affected of related to circulation, because 20% of your blood is going through your 20 to 25% is being pumped through your kidney. So if there's some problem with the heart, definitely it can cause AKI if it's not if it's not well managed. And what else? Some other diseases. Let's say patient is with cancer and getting treatment for cancer, so your chemotherapy would definitely would affect your kidney function. If given you have a baseline kidney function that is really a little elevated, so that would really add to the problem. So the exposure and the susceptibility to this is really high for those patients admitted in the hospital. I've read in I believe that's KDIGO. So the problem with kidney disease, we don't have baseline creatinine for those patients most of the time, unless they are really following up with other diseases that would require checking their creatinine level.
Yeah. Okay, thank you. We are at time and I don't see any more questions. So I just want to thank our presenters again. I'd also like to thank our audience today for your participation. We hope you enjoyed the webinar and found the information helpful to your practice. Bye.